Around 100,000 infants a year die globally due to RSV, of which the vast majority are in low and middle income countries. But in the last few years, obviously there's been major breakthroughs. The vaccine seems to work in a real world setting as well as it did in the clinical trials.
Welcome to the Peds Round, and we're recording a new podcast this week on a topic that is very close to my heart, both as a general paediatrician and as an infectious disease specialist. And it's my great pleasure to have a real expert in the field, Simon Drysdale, to come and chat to us. So Simon, would you like to introduce yourself?
Thanks, Emma. Thanks for inviting me. So I'm Dr. Simon Drysdale. I'm a paediatric infectious diseases specialist at the Children's Hospital in Oxford and a senior lecturer in vaccinology at the University of Oxford.
Perfect. And today, this is very appropriate because as I was driving along on the news, it said that we've had a really bad winter. All the beds are full. We've got a lot of RSV or respiratory syncytial virus around. So why is RSV such a problem? And why do you think that we should have introduced vaccines for it?
Thanks. So hopefully everyone will be aware RSV or respiratory syncytial virus is an extremely common virus. Every child gets infected within the first 2 to 3 years, and it causes disease ranging from mild upper respiratory tract infection through to more severe disease such as bronchiolitis or pneumonia, or even in some cases death. We know that, as you've just alluded to, as general paediatricians, we know during this time of the year, A&Es are completely full, the wards are full, intensive care units are full. We end up having to cancel elective surgery because there are no beds, and the overall healthcare sort of burden is massive. And I mean, just to put some numbers on that, in the UK, somewhere between 20 and 30,000 infants are hospitalised each year, and that's around 1 to 2% of all babies born. There's many hundreds of infants admitted to the intensive care unit, and there are hundreds of thousands of GP admissions. To put into the sort of slightly wider context, around 100,000 infants a year die globally due to RSV, of which the vast majority are in low and middle income countries. And there are tens of millions of infants with lower respiratory tract infections and those that end up in hospital. So this is a disease that causes a huge burden in infants in the UK, but also globally.
Fantastic. Yeah, and I think I have this theory. I have a theory that viruses are like a second-rate relation. Everybody is very focused on bacteria. We've got lots of choices of antibiotics, and immunizations have typically focused on bacterial infections. But what we see in the population, as you described, is this huge burden of viral disease now.
Yes. And, we've known for a long time that viruses have potentially caused the biggest burden of disease. They, circulate regularly. Everybody gets RSV every couple of years, but it generally tends to be less severe once you get past infancy until you get to older age groups. And so we've been looking for a vaccine for RSV for many years, since the 1950s when it was first sort of identified. And there have been various sort of ups and downs over the various years of trying to develop a vaccine. But in the last few years, obviously, there's been major breakthroughs. And so in the last two and a bit years, we've had 3 vaccines licensed for older adults, 1 licensed for pregnant women aimed at protecting the infants, and also a long-acting monoclonal antibody called nirsevimab, which has been licensed to protect infants. And of course, we've had palivizumab, the sort of short-acting monoclonal antibody, for many years. But the downside with that was it required monthly injections and was very expensive, so it wasn't really suitable for most infants. So there's been an explosion of preventative therapies for RSV in the last couple of years, and now we're in the process of trying to roll those out across the UK and other countries.
Really exciting. So as a paediatrician, I'm not interested in the 3 for older adults. Why did you target pregnant women to vaccinate them rather than vaccination that could be introduced within the routine schedule?
So there's a few kind of reasons for that. I mean, both approaches are perfectly reasonable, and the monoclonal antibody is designed to be given essentially at birth and therefore provide protection from birth. And likewise, the maternal vaccine given to the pregnant individual, they mount a response to the vaccine, and then you get transplacental transfer of the antibody to the baby, and so the baby is therefore protected directly from birth.
Your idea is that you would vaccinate a pregnant woman, they would mount a response, and that immune response would cross the placenta, and so a baby is born immune. It's like hitting the ground running. So from the moment they're born, they are immune to RSV. Is that correct?
Yes, yeah. And there are other examples, influenza vaccine for pregnant women, COVID vaccine, and pertussis vaccine, where particularly pertussis is a good example. The vaccine is given to the pregnant individual, not so much to protect them, but the antibody goes across, and therefore the baby is protected immediately that they're born, rather than having to wait for their first vaccine, which would be at 2 months of age, for example.
And that's really important because babies die in that first month from respiratory illnesses like RSV and whooping cough. So tell me, this year in September, we were due to roll out the maternal RSV vaccine.
Yeah. Yes. So the vaccine programme started in the middle of August in Scotland and the start of September in the rest of the UK. Obviously, the decision to start the programme was made relatively soon prior to that. So it does mean everything's been done at a fairly fast pace. So therefore, probably as expected, it's taken a little bit of a while for people to be familiar with it, to be familiar with what RSV is, because it's not the most well-known virus outside paediatric circles. The delivery of the vaccine through primary care and obstetric and midwifery services, again, takes time to build up, and for staff and patients and pregnant women to be familiar with it. So at present, around 100,000 pregnant women have been vaccinated so far. Clearly, there's scope for things to improve, but overall, it's not so surprising for a new programme that was started fairly quickly that there are some teething problems, but one would anticipate over the coming months and future seasons that things will improve.
Okay, so really exciting. So we started in August to September, and a pregnant woman can get the vaccine from their GP or from their midwife. How far along their pregnancy should they be to get this vaccine?
So the vaccine is recommended from 28 weeks gestation right through to delivery. The advice is the earlier or closer to 28 weeks that women receive the vaccine, the better chance there is to mount a response and therefore pass on as much antibody to the baby as possible and therefore provide the most protection. But even receiving it later in pregnancy is more beneficial than not receiving it at all.
So let's say you're like me and you work on a last minute basis. When is the last effective time a woman can get vaccinated for RSV in her pregnancy?
So the vaccine takes around 2 weeks to take effect, let's say. So if the woman is vaccinated less than 2 weeks before the baby is born, then certainly the response is going to be less than ideal. So ideally, you want to be vaccinated at least 2 weeks before the baby is born, but preferably more than that.
So what are the pros and cons of vaccinating mothers rather than babies?
So the advantages, if I start with those, or obviously it's one less vaccine for the baby who already has many vaccines in the first year or so of life. There's definite protection straight from birth. So unlike the monoclonal antibody, where there may be a bit of time before the baby necessarily receives the injection, where they'll be vulnerable, we know from if they receive mum has received the vaccine, the baby will be protected directly from birth. There's also the advantage that the pregnant woman will receive protection from the vaccine. So whilst that's not a big burden of disease, it certainly has some advantages, and perhaps may even result in some reduced transmission in households, although we don't know that for certain. Programmatically, it's a little bit easier. It's a year-round program, so pregnant women are vaccinated all year round, whereas a program for infants probably would be seasonal, which is a little bit trickier to do from a NHS perspective. And then the last thing is it probably is cheaper to have the vaccine than the monoclonal antibody.
A vaccine protects the mother and the baby and possibly reduces transmission for the whole family, and that you can give it any time of the year. But there must be some downsides. There are always downsides. So what are those?
Yes. So as we've already alluded to, if the baby is born prematurely, then there's little protection or potentially no protection for the baby. And of course, this is a fairly new program, so there'll need to be ongoing surveillance for any adverse outcomes that are rare.
Okay, but exciting times. And I know that, we're always a little bit behind on the vaccine front, so there are other countries who are already using it. Has there been is there exciting news from other countries? The States, United States of America, Australia, or Argentina?
So last season, several countries started using the maternal vaccine. In particular, Argentina rolled out their program for the last RSV season, and they've recently published some real-world data showing efficacy that was similar to that found in the clinical trials. So that's reassuring that the vaccine seems to work in a real-world setting as well as it did in the clinical trials.
So I think that means there were less admissions to hospital and to paediatric intensive care. And also there was a nice effect that older people were also protected, or there was less admissions in the elderly. Is that right?
So many countries have also rolled out an older adult vaccine program, much as we have just started in the UK. So there's, again, good real-world evidence from the US that there was significant protection for those older adults who received the vaccine. So again, encouraging that in a real-world setting, what they found was similar to what they found in the trials.
All right. And so one of the other things that people ask, so we've got this fantastic new vaccine. We know it's worked in other places. So we've got some real world data. That's really exciting. I guess one of the questions was, does it affect babies' immune response to their routine vaccinations? So if you had maternal priming, if you were already immune to an RSV, and then you had your routine vaccines, which you have to mount an immune response to, is there any problems?
So there's no evidence that infants born to mothers who've received maternal vaccines have any significant impact on their routine vaccines. And all pregnant women will pass on RSV antibodies to their baby because they will have had RSV previously. So the purpose of the vaccine is to boost that response up.
They're going to give them antibodies anyway, but they're just going to give them better quality antibodies because of the vaccine.
Exactly, better quality and more of them.
Fabulous. So is there any problem persuading mothers to get vaccinated, or are they what's your experience been of persuading pregnant mothers to get vaccines?
Well, I think the evidence suggests it's still pretty early. and there's no hard and fast evidence available at the moment. But as I alluded to, more than 100,000 women have received the vaccine so far, which suggests reasonable uptake. We're still waiting for the final figures on that, but I think it's been pretty well accepted overall.
Yeah, I think it's a really great idea, because you know that women are coming for healthcare, and this is a preventative health, so they've got to come to receive antenatal care, and so you're actually doing something preventative. So I really like the idea about this. We talked about maternal vaccination, we talked about the pros and cons, we talked about why it's good, we talked about how it's worked well in other countries, and that we all should be doing it. But let's say there are a population of children who are very at risk of RSV, and once they're born, you can actually vaccinate them. And you were telling me there were 2 different monoclonal antibodies. So previously, we've used palivizumab, which is a short-acting monoclonal antibody, and only lasts for a month. So the poor children have to come back and be vaccinated every month. But there's something new, isn't there now? What's in the bag?
So the new monoclonal is called nirsevimab. So it's a long-acting monoclonal antibody. So one dose at the start of the season will cover for 5 or 6 months. And that's been licensed, but at present is not currently available in the UK. It has been used in other countries, and there's good evidence of real-world effectiveness, but it's not available in the UK.
Is that just because we're slow, or we're cheap, or we can't afford it?
Either the vaccine or the monoclonal antibody would be cost effective. And so the recommendation from the Joint Committee of Vaccination and Immunisation around a year ago was that either product could be cost effective, and therefore the government put out a tender to companies, and ultimately it was the maternal vaccine that was taken up.
And I guess there's some benefits, because, as you suggested, the mothers get some immunity. So that's one thing. And the households. And we do have a short-acting monoclonal antibody, so it's not as if we don't have anything. Is it likely to be something that we start using in the future?
So for the highest risk babies, we have palivizumab, as you say. It's the babies who are slightly lower risk, for example, those born moderately prematurely, who may not get maximal benefit from the maternal vaccine, who would benefit most from an alternative option. I think it's likely in the coming years that we will have nirsevimab or another similar long-acting monoclonal available for this cohort of infants. At the moment, Sanofi, who make nirsevimab, obviously are trying to supply it to many countries across the globe. And so it's somewhat of a sort of supply and demand issue, that they can't supply it to everybody that needs it or wants it. So the infants at highest risk are those with chronic lung disease of prematurity or bronchopulmonary dysplasia, those with significant congenital cardiac disease, and those with significant immune deficiency, for example, those with severe combined immune deficiency. And then there's also another group of slightly older children, those who are on long-term ventilation. And all this guidance is provided in the Green Book on Immunisation, which you can easily Google.
Absolutely. The Green Bible, use it often. We've talked about who's at highest risk. We're talking about short and long-acting monoclonal antibodies, but how do they work?
So the antibodies work by getting to the mucosal surface in the nose and the lung, and preventing the virus from binding to the cells on the respiratory tract. So if the virus can't bind, it can't therefore get into the cells and cause inflammation and disease.
And the monoclonal antibody we have available at the moment is palivizumab, which is a short-acting monoclonal antibody. And you said it lasted for about a month. So what are the pros and cons of palivizumab?
So for many years, the only preventative we've had is palivizumab, and we know that it is effective. It reduces the risk of severe RSV disease in high-risk infants by up to 80%. And there's even a little bit of evidence that it prevents, by preventing RSV disease, it prevents those infants having longer-term respiratory problems. So it certainly is a product that is useful for high-risk infants, but the major downside is it requires an injection every month over the RSV season, and it is extremely expensive.
Yeah, that doesn't sound ideal. So there's a new longer-acting monoclonal antibody that's become available. It's another MAB. I can never say them. So this one is now's your time to shine.
Nirsevimab.
And tell me about the pros and cons of nirsevimab.
So nirsevimab is a long-acting monoclonal antibody. So it lasts for essentially, or provides protection for at least 6 months. So the big advantage there, of course, is you give one dose at the start of an RSV season, and that protects the infant for the whole of the RSV season. So therefore, far fewer injections, far fewer trips back to hospital, and therefore also a reduction in the cost because you're giving fewer doses and fewer healthcare attendances.
Fantastic. So it sounds good, but it's not yet available in the UK.
No, so unfortunately, it's not yet available in the UK. It has been available in other countries for last season, and there's lots of data coming out showing in the sort of real world setting, it's very effective, significantly reduces hospitalisation due to RSV, and even reduces primary care attendances. So it certainly works. It certainly is very effective, but as it's a new product, the company can only supply so much at the moment, whilst they're in the process of increasing supplies. So it's not available to every country that would like it yet, including the UK. But we have a maternal vaccine, which provides protection for the vast majority of babies. So at this point in time, we would only be looking to use nirsevimab for a relatively small number of babies anyway.
So fascinating. I feel like I know almost everything there is to know about RSV and vaccination now. So will you give me your what's your 3 top tips, top learning points about RSV vaccination?
So I think the main thing is we've gone from a couple of years ago having one product that was only available for very high risk infants to now having something that can protect essentially all babies, and therefore make significant inroads into that huge burden of disease that I talked about at the beginning. And what we would like to think is that we will, in the coming years, not have our paediatric wards and departments completely full of these children with RSV, bronchiolitis, but will have significantly reduced that burden, which is good for the children, of course, and their families, but also means we can potentially prioritise other things from a healthcare perspective.
Fabulous. I mean, you're completely right. This is a serious disease that children are admitted to hospital for long periods of time. They're admitted to an intensive care unit. We have no current effective treatment. It's only supportive care. So really, this is a game changer.
Yes, it's been a long time coming, but we seem to be heading to the point where we can massively reduce the burden of RSV. And so, as you say, we're at probably a threshold where we can make serious inroads into that burden. And we must also forget that, of course, the biggest burden is in countries that don't have access to the vaccine or the monoclonals at present, so many of the lower middle income countries. So whilst it's good for us that we can reduce our burden in the UK and other high income countries, of course, the biggest areas of mortality are in other countries that at present don't have access. So we must try and improve that in the coming years too.
Absolutely. I think this global outlook on disease is so vital. Anyway, Simon, it's been a real pleasure to talk to you. I feel a sense of achievement, A, that we have a vaccine, and B, that we've got to the end of this interview.
Thank you very much. It's been a pleasure.
I think we can go and crack open the champagne now. And I shall be here, hopefully with all that time on my hands, because the emergency department will be like empty, like a ghost town.
That's the hope.
The Royal College of Paediatrics and Child Health had a significant role in ensuring the RSV immunisation programme was introduced in the UK, following the publication of the Joint Committee on Vaccination and Immunisations recommendations. In March 2024, the college published an open letter signed by over 2,000 RCPCH members, urging the government to implement a full RSV immunisation programme for both infants and adults across the UK. This letter generated media coverage and UK parliamentary attention, with MPs and Peers supporting the call, which in turn put pressure on the UK government to respond. As a result of the campaign, the RCPCH welcomed an announcement from all 4 UK governments confirming the rollout of the new RSV programme for infant protection from August 2024 in Scotland and September in Northern Ireland, Wales and England.
This podcast is produced by Odland Education. The views, thoughts and opinions expressed in this podcast relate solely to the speaker and not necessarily to their employer, organisation, the Royal College of Paediatrics and Child Health, or any other groups or individual. You can find a wealth of information on the important work of the Royal College of Paediatrics and Child Health on rcpch.ac.uk or #ChoosePaediatrics.